Hi there. Today, I wanted to share with you a topic which is very, very close to my heart, and that is the essence of limb reconstruction. I get this question a lot, and today, with the help of a case, I would like to share what reconstruction really means to me. So, this was a 50-year-old male who was a mechanic by profession, and he sustained this fracture while working in his garage. As you can see, this is a distal third ulnar spiral fracture, very good surface area of contact. There's a tad bit of malalignment on the AP view, reasonably okay. The distal radio-ulnar joint seems to be all well. The lateral view seems to be showing a tad bit of variation in terms of alignment. So now, myself and my team, we decided to go ahead and think what is best for the patient. Whether should we open and reduce, whether we should do a closed reduction and casting, or any implants specifically to be ordered for fixation, a rush nail, or let's say a simple K wire, or just a mini fixator, or out of the box, a plating. And because we wanted to give him utmost stability and early return to function, we decided to operate. But at the back of my mind, I did think if it can be conserved. So, anyway, this is what we did. The x rays here show a recon plate which has been applied, and through the recon plate, a lag screw has been placed in order to attempt at fracture reduction. The first x-ray shows that it's all well, but still I am a little concerned about the distal most screw, which may be protruding into the joint. However, on table, while taking a C-arm shoot, it looked fine. But these x-rays, better resolution, give a different picture altogether. So what I did is I rotated the hand a little, and here I can see in the middle and the extreme right side x-ray is that the lag screw is in fact pushing the distal fragment much further. Probably it is going to cause problems in the future. And this is where the jitters begin. So at that time, anyway, there's nothing that has to be done. But at 6 weeks, when the patient has come back in a slab, here as well, I can see that the there is a slight collapse of the distal fragment, and probably the screw at the distal most end is very much into the joint. Now, the concerns. As a surgeon, is this going to fail? He's a mechanic. This is his right hand. He has come to me with high expectations. And in retrospect, would a cast have been a better choice? But what exactly do I want to do at this stage is if I could, I would turn back the clock, which is not really in my hands. But yes, it is a wishful thinking in progress. So, a colleague of mine took another x ray and told me, you know what, it doesn't look too bad. Look at this alignment. But I knew that the reality is much further from that. At this stage, I discussed the options with the patient and decided to go on and see how the fracture behaves. Somebody did comment and tell me to revise this. At 12 weeks post op, I decided that this fracture is now giving me a little bit of a ray of hope. As you can see, there is a bit of a callus at the fracture site, which is attempting the fracture to unite. I do agree there is a collapse. I do agree that the implant looks much more proud than where we started off. But is this enough? Is this ray of hope just enough for us? So, what I did is I called the patient and I examined. What I found was that he did not have any kind of tenderness at the distal tip of the ulna, and his wrist range was fine but not good enough. So what was our thoughts whether we have to intervene or not? Removing the screw at the fracture site, which is pushing the distal fragment away, is it a good enough option? The implant needs to be removed and completely realigned with callostasis, or just remove everything and put a mini fixator in proper alignment for stability. So, but before that, retrospectively, I assessed, is there a problem with the alignment? Reasonably looks fine. Is there a problem with the biology? I don't think so. Otherwise, callus would never be formed. I do agree that this should have united without any visible hypertrophic callus like we have seen in the previous x-ray. But yes, the body is trying to heal, and that is something which one should not ignore. It should have united with primary intention, no doubt about that. But regardless, it is uniting, and that needs to be paid attention to. Is there a problem with the implant? Yes, there is a problem with the implant, and I take full responsibility for it. At the distal ulna, the screw may be intra-articular, and in the x-rays that are done, it does look intra-articular. But is it causing pain of any sort to the patient? I did not have any of those features when I examined the patient. Is there a problem with the primary fixation technique? Yes, we could have done better. We could have used a better implant. We could have settled with two screws instead of three screws with adjustment of the plate in order to ensure that it isn't proud. Is there a problem with the surgeon? Yes, there was. And I take full responsibility for it. So at 12 weeks, here are the clinical images. He does have stiffness. But if it was really, really bothersome, he wouldn't have had this much range as well. I do agree it should have been better, but this doesn't look too bad. So I waited it out before intervening for another 4 weeks. So we waited this long. What's another 4 weeks? So at 16 weeks, this is what I found, that the fracture has almost united in the AP view and in the oblique view. If you can see, the fracture seems to have bridged with callus. And yes, I do agree that the implant is backing out. I do agree the screws are backing out. But yes, there is union. And that is why I wanted to share this case, that I have done nothing but wait and started the patient on early mobilization. So this series of x-rays along with this clinical picture, I believe has taught me much, much, much more than any other case for limb reconstruction in the last 16 months that I have been back after my fellowship. So, what really is limb reconstruction? Going back to this image tells me that limb reconstruction sometimes is all about patience, anticipating that a fracture would unite and anticipating that it may not, balancing these pros and cons, discussing honestly all of these with the patient while enduring their questions and concerns, but inherently having a much needed ray of hope will always get you to the end of the tunnel. And the determinants of a fracture to heal should always be weighed technically. As per the questions that I discussed, whether there's a problem with the alignment, whether there's a problem with the stability, whether there's a problem with the biology, against the clinical image, which is something that we always forget. But yes, clinico-radiological correlation is a must in all the cases. And giving time to cases of this sort where the body always keeps telling you, for example, like in this case, at 8 weeks, probably it's not uniting or it's not going to unite, but definitely keeping it simple, giving a little bit of time, believing in the process, and looking at the signs radiologically will definitely help you learn much more about limb reconstruction than a simple, straightforward case of fracture union. I do agree there are some concerns, but yes, this patient and his journey with all the parameters that I have discussed with you today have taught me a lot of things. And most importantly, like I said, patience. And this is what I wanted to let you know as on today's date, that limb reconstruction is about analyzing the fracture. Limb reconstruction is about understanding what the fracture is trying to tell you. I deal with non-unions, I deal with malunions, I deal with maybe badly done cases. In this case as well, I take full responsibility. But yes, sharing my journey with you through my failures, through patients who have high expectations, and this case has taught me a lot of things, which is why I wanted to make this video today and let you know that anticipation, hope, patience, and a great deal of analysis will get you where you want to be. This patient is planned for implant removal and early mobilization, and I believe that in the next 4 weeks, the only way from there is up. And I would really like to know if you have any thoughts on this case that I have presented. I would be very happy to take your comments, criticisms, and suggestions as well. Thank you so much. We'll meet again.